the news is always a little depressing. And I don't like to give bad news if I can help it, but yet this is hard to deal with, and we all have to deal with it together. And so let's go through some of the bad news stuff first, and maybe we can get that stuff out of the way and then see if we can talk about potentially some solutions. What's going to happen with healthcare? Well, with healthcare, I can kind of break down healthcare into 4 big problems, and they're big. The first one, perhaps the biggest problem, is costs. But there's also problems of complexity, of fragment of care, of the lack of information among people. So we talked about healthcare costs. We can talk about how providers deal with them. We'll talk a little bit about each of those and how they're dealing with them. How will insurance remain relevant going forward in the future? What's the future of insurance? And then how will employers solve problems? And then what about patients? That's kind of where we're headed today with the presentation. So, are costs a problem? Well, everybody can say, duh. Of course they are. But I don't know if we recognize the magnitude of the problem. So last year in the United States, Americans spent $2.9 trillion on healthcare, with a T, not with a B, $1 trillion. That is more on healthcare from the U.S. than most other countries' entire GDP. So, for example, Great Britain's GDP last year was $2.7 trillion. The U.S. spent more on healthcare than the entire GDP of Great Britain. And you can see Italy, where Italy and Mexico fall down. That amounts to, if you take that 2.9 trillion divided by the population, 9,255 for every man, woman, and child that live in the country. And that's a staggering number if you think about how much that is. So if you're looking at healthcare costs per capita, you can see that they've continued to go up, and here's our this year, 92.55. It's easier to see on the handout probably than right here. Just to give you kind of a perspective of what that looks like, if you have a family of 4, that's just over $37,000 for your family in a year. That's more than the average new car. It's more than a $400,000 mortgage for a yearly payment. It's more than the average kitchen remodel. And all these trends go up. As a share of GDP, this continues to rise. Actually, this ends at about 2010. It's been relatively flat since then, so it's still about 17.5% of total GDP that America spends on healthcare. By some estimates, about 25% of healthcare costs are unnecessary or for unnecessary services. So let's talk about complexity for a second. Is that a problem? How do we deal with that? So we have the complex American system of healthcare is unparalleled in the world. Not only are the costs higher, but the complexity is way beyond anywhere else you see in any other country in the world. There's this huge regulation of federal and state law that deals with every facet of healthcare and how it's working. On top of that, we have the insurance industry that puts in terms and ways to try and limit those costs, but that creates an added layer of complexity. And what happens is that most of the time patients get caught in the middle. Most of us have a story of someone who has either needed some kind of treatment or had expensive treatment they needed, that they actually had to go out and try and raise money themselves to try and pay for this treatment, rather than trying to rely on either the government or insurance or some other way to pay for it. And sometimes, even if insurance covers it or the government covers it, it still isn't enough that they really can afford the treatment that they're looking for, the treatment that they need. And so we've resorted to the healthcare of bake sales, is what I like to call it. And so you have the bake sale, or you have some kind of Facebook say, please support my GoFundMe campaign that I need healthcare and this is what's happened to me and it's not getting covered. The government complexity is well known. We have all this regulation, and those are some of the alphabet soup of the federal government regulation. In the state, we also have DOPL, who regulates providers. We have the insurance department. We have Medicaid. We have on and down the line. We have lots of different regulations internally. So this is sort of a satirical look at what the ACA looks like, simplified, and it gives you an idea. And you can't read it, and you're not supposed to be able to read it, and that's okay. But here's how the ACA works, if you wanted to get an idea about how it's supposed to work. If you really wanted to know, I mean, Health and Human Services is a big part of it, but the IRS really should be about the same size, and if you really want, they're the ones that are going to take over the real regulation going forward here. So you know most of these. Here's what's happened prior to 2014. We had all these new insurance regulations that changed the way that you provide insurance for your employees and for employers. The big one on this one is the preventative care covered at 100%. And there's a couple of slides here later. We'll look and see what the effect of preventative care at 100% has been and what it's going to be going forward. The other big thing that happened last year is the federal marketplace is opened. They have what's called community rating. That means that the most expensive plan in the marketplace and the lowest cost plan in the marketplace have to be within a certain ratio of one another so that the younger, healthier people pay more and the older, sicker people pay less. And so the ratio is 3-to-1 right now. Everybody's eligible for coverage, but the pricing is fixed within this range. Subsidies are available if you're lower income. We'll talk a little about the subsidies here in a minute. But you can look and you see what a 35-year-old Salt Lake County Silver plan would look like and what a 55-year-old Salt Lake County Silver plan looked like. That's for 2015.
What are the two numbers there?
So this is individual coverage or family coverage. So 202 for individual, 635 for family in the same down here.
Is silver 60% or what?
Silver is 80% of the cost of medical care, and that's what the subsidies are based on. I would guess that most of your plans, employer plans, would compare with a silver plan. It's pretty equivalent to a typical employer-based plan as a silver plan. Gold would be a little higher, and then bronze would be a little bit lower.
Isn't the silver the lowest qualified plan that you can have and be considered covered?
No, you can have the bronze plan. So they have a bronze plan that covers 70%.
Is that still considered insurance coverage under the IRS regulations? Because I was told it was not through a tax advisor.
It is. So there's a question of what is minimum essential coverage.
There you go.
That's what you're talking about, I think.
For the silver.
For the silver plan. So minimum essential coverage, you have to cover at least the bronze level. So you have to cover at least 60%. So you're okay at the bronze level. The silver would be above that. Okay, so if you look at what the marketplace did for individual marketplace. So marketplace plans are individual plans. They aren't group plans. There's no employers participating in the marketplace. If you look at the comparison of the individual plans, there used to be a lot of low benefit individual plans out there. So it didn't surprise anybody in the insurance industry that the premiums increased 41%. The biggest issue there are a lot of benefits had to come up to a certain level that the federal government mandated. And so the first year there was going to be this huge increase. So across the country they increased 41%. In Utah they increased 24%. But you can see it was different depending on who you were. If you were 27 years old, you got a 55% increase. If you were 64 years old, you got a 2% increase in costs from 2013. That was 2013 to 2014. They continue to go up a little bit this year. Hopefully those stabilize. The other thing to know about the exchange is that there are also winners and losers depending on where you live, your gender, how old you are, and you can see kind of where the winners and losers were. For the most part, Utah ended up in the winner category here for the exchange, at least the people that got on there, but in general. So let's talk a little bit about the lawsuits. There's an Italian proverb that says that a lawsuit is a fruit tree planted in a lawyer's orchard. And so this is a great thing. And I thought the ACA is the perfect opportunity for a great orchard for all of us lawyers that like to look out there and say, what can we do? Well, the ACA can always sue over that. Everybody else has. So King versus Burwell is the latest challenge. It's before the Supreme Court right now. It talks about the ACA subsidies. And in the ACA, it says that you only get subsidies in the marketplace in an exchange established by a state. And so the federal government has argued, well, an exchange established by the state, everybody knew that meant the federal government as well as the states. The states are arguing, no, that only means one of the 50 states of the United States. If you don't have an exchange set up in your state, you don't get subsidies. Utah decided not to do an exchange that would meet the federal requirements. They have an exchange separate from that, Avenue H, completely separate. They don't get subsidies. So potentially, if the court sides with the plaintiffs here, it would invalidate all the subsidies for the people on the marketplace in Utah. There are 140,000, I believe. Let's see if that's the next slide. Maybe not. 140,000 people in Utah that are on the marketplace right now. Approximately 85 to 90% of those are eligible for some subsidies in the marketplace. So you could be looking at maybe 4% of the population of Utah that would lose money if they side with the plaintiffs here. Now the fix to this is really easy. The problem is that Congress is dysfunctional completely, and they can't do anything about trying to fix it, but the fix is really easy. So there's a couple of things. The first one is the easiest, is they could just amend this provision to say states or federal government, and it would be over. We wouldn't even have a lawsuit, it would be done. The second thing is that Congress could extend the subsidies, and you're even having some Republicans talk about that, in the federal marketplace for a short period of time, like a year, 8 months. And then they could say the states can figure it out from there. And the third thing is, what will be interesting to see, is that the states could allow an exchange run by the feds through some agreement. And so the fix to this is really simple, but it's all political. And it gets bogged down in that political process. It'll be interesting to see what happens if the court rules in favor of the plaintiffs. I think they very well might. But then what happens as far as the remedy goes if they rule for the plaintiffs will be interesting to go. But it'll be a big deal for people around. Even without that, there's a dirty little secret about the subsidies in the ACA, and that is that they cap all the subsidies at 0.54% of GDP. So in today's dollars, that's about $95 billion in subsidies. That seems like a lot of money. But what we've seen from this is that if about 25 to 30 million people reach or go on the exchange, with where the subsidies are right now, they will hit this number. So right now you have about 11.7, that was the last number that I saw that the federal government released, people that are on the marketplaces nationwide. If that number doubles, roughly, 22, once you get to 25 million, you have to start watching this number, because even if you get rid of King versus Burwell, this is still out there and it's going to be an issue going forward. The federal government estimates that they'll end up with 30 million people in the exchange. It's entirely possible that they'll exceed that threshold, and the subsidies will have to come down for those people, will make it less affordable for them to buy coverage going forward. Okay, this one's a little bit hard to read. Maybe this when we were talking about this, and maybe we've already touched on all these issues. But basically, in Utah, 140,000 people are enrolled in the marketplace, and if we get to 30 million people, we're going to be have some problems. Some other issues of federal complexity. The ACA has been a little bit of a moving target as far as employer penalties go. And I know you've probably had more employer penalty discussions than anybody ever would want to possibly have. They've been delayed for this year. For this year only, it went from 50 to 100, so the penalties only apply if you have 100 or more employees. It only applies this year if you have 75% of your employees that are covered. You have to have at least 75%, and that goes to 95% in 2016. And then there's the new reporting requirements. I'm sure you know about the new reporting requirements. Happy to talk about them if anybody wants to just have their eyes glaze over in the back of their head about how that works. What I did want to emphasize is that if you're with PHP, PHP does the reporting for you. And that's a big deal, that they take the responsibility to collect all the information that you have, to be able to put it in the forms for the federal government, and then give that back to the employers to have them file.
So David,
Yeah.
that means then the PHP is literally going to prepare the tax forms that are required at the end of the year for us?
We'll prepare the tax forms, we'll send it to the employees. The tax forms themselves we'll send back to you for your signature, and then send them out. But we will fill the whole form out. All you have to do is sign it and send it.
Oh, attaboy, I salute you, sir. Thank you.
That's
Well done.
the beauty of being able to have all the info in one spot. So.
That's great.
The other thing that is big on the item right here, and Representative E ducked out before I wanted to hit him up on what's going on with Medicaid expansion. But we have Medicaid expansion is a big issue in Utah. As you know, it allows an expansion of this program for people that make higher incomes than we currently have now. So the feds pay for the cost of expansion for 2014 to 2016. And then in the next 4 years, the cost of expansion is gradually shifted back to the states. Utah found it would cost $100 million between 2017 and 2023 to expand. And the state hasn't made a final determination. So they got closer to a decision this year than they ever have. And it bogged down between the House and the Senate, and they couldn't agree how to make that work. And Governor Herbert was obviously involved there. Okay. I lost but there, this gives you an idea about what it might cost. So this is with 2014 numbers, so they have to be adjusted for 2015 now. But if they did no expansion, there's still some expansion of Medicaid. This is what it would cost the state in 10 years just to do nothing, $220 million. If they expand, this is sort of the Help the Utah program that the governor has encouraged. It would cost the state $378 million, but the short term there's a savings of several $1 million.
So that 378 is based on Congress not extend, like on subsidies ending at that point.
This the gradually pushing it back onto the states over 10 years. That's the idea. And then the partial expansion, which you wouldn't get any federal subsidies, and it's even the most expensive of all, and that causes people significant consternation, this kind of number. So even either of these, it's difficult to try and deal with it. How do you deal with $220 million over 10 years or $22 million a year? That's money that comes out of your pockets in some ways. It comes out of schools, it comes out of roads, it comes out of everything else that the state might want to cover. And it doesn't really matter what you do, you're going to be paying $220 million unless you want to get rid of Medicaid altogether, which I don't know if that's on the table either. So that's where we are. I'm going to come over here. This is not going to work. Okay, the other state complexity that's going on is that there's ACA adjustments to benefits. So there's preventive care benefits or and essential benefits. And one of the big state adds to this year is the autism benefit. The autism is now going, a benefit for autism is going to be required for every employer that has more than 100 employees beginning next January. So if you don't cover autism right now, you'll have to start beginning on your next renewal, beginning January 2016. And what that benefit is a mandate for 600 hours of behavior therapy. The small groups don't have to do it. They encourage everyone to do it, but they don't have to if they don't want to. The other big part of complexity is there's the complex insurance lingo, and so most of you will know these terms, but the average person maybe doesn't know what deductible or out-of-pocket max or copay, co-insurance, allowed amounts, pre-existing conditions, all those things mean. And there's also the internal rules as far as insurance companies go, pre-authorization or exclusions or limitations. Those are where the lawyers make their money, and step therapy, things like that. Well, let me go back. One issue at the very bottom of that was ICD-10. So the way that doctors bill for services is that they perform a service, they have a code that they assign to that service. And the American Medical Association, along with Medicare, helps to create these codes, and right now they're using the ICD-9 codes. In October this year, they're transferring over to ICD-10. It has a potential enormous disruption to the medical profession. The codes go from there's about 40,000 codes right now, and they're estimated to go to about 140,000. And so the codes will make a distinction between right and left for every type of thing, and maybe even quadrants or parts of your arm. If you have something done to your arm, is it the upper arm or the lower arm or underneath or on top? And so there's different codes depending on where that's all going to work. You ought to be watchful around October when this is supposed to take place, because not only will this cause disruption across for just trying to get into services, but it will cause disruption potentially with payment of services as well. So it's something to watch going forward about how that's going to work. They've already delayed it 3 times. I don't think they're going to delay it again. We'll see. Fragmented care is the last big problem. And if that's a problem, we have gone from the town doctor taking care of everybody in the town to what we have now, which is sort of we want to be all things to all people. So let me give you an example of what fragmented care looks like comparative to the rest of the world. The U.S. provides almost everything. We have public hospitals, public doctors, private doctors. We have private insurance. We have individual mandates. We have public insurance. We have supplemental insurance. The only thing we don't do is we don't cap prices. And so there's no price fix. And you can see almost everybody else caps prescription drug prices along the way. And you can, if you wanted to look at it, it would be interesting to look at cost comparative here, because the more yeses you have, my guess is the higher the costs are. And you can see how fragmented that system would be. So there's this feeling of helplessness. That's the bad news piece of this. And what do we possibly do? You know, especially as individuals or maybe as one employer even, how can we possibly affect any kind of change here? So let's talk about what's going on with providers in the future. Providers in 1999 were roughly split the cost between hospitals, doctors, and drugs. You wanted to take a really broad picture about where they were. Hospitals were a little bit more, but not a significant amount. By 2013, the hospitals were 51% of the costs. The doctors stayed about the same, but the drugs as percentage came down. And what happened with the drugs is that people really drove to generics during that time period, and a lot of drugs came off of patent and became generic. And so you saw prices fall with competition there related to generic drugs. The hospitals, though, is concerning. None of these prices went down during this time period. So the hospitals more than made up for it with all the other costs that they have going on. So how do we possibly save costs with hospitals? One of the things is that the hospitals are trying to do is reduce administrative costs. And the thing that they're going for is what's called an accountable care organization, or ACO. You're going to hear a lot more about this with Intermountain in particular going forward, and they're going to be trying to be the first ones in Utah to try and go this direction. And what that means is that they have everything that you could possibly need in one silo. You never need to go outside of the Intermountain system. Once you're into their system, they get paid just a flat fee every year for everyone that's in their system. It's a capitated type system. So they get this chunk of money, and then if you use very little services, they get extra. If you use a ton of services, they take a loss on it. So Intermountain themselves is going to have the risk of whether people do well or whether they don't do well. The hard part with Intermountain, and does anybody work for Intermountain in here? The hard part with Intermountain is that they're driving everyone to the hospitals. They care about the hospital's health, and the hospitals are the ones that are really expensive. And so the whole idea of the Accountable Care Organization is trying to get people into a lower level of care, but Intermountain's model is not based on that. So I'll be interested to see how this works for them, but it's an interesting concept that they want to say, okay, we'll take all the risk, and we don't need to worry about billing or any of that other stuff. We'll just take care of these people. The other thing that they're doing across the board is they're trying to use technology in new ways. So you'll see electronic medical records become more popular, but one of the other big things that you're seeing now is things like telemedicine. So if you live in a rural area, can you see the doctor, a specialist, say in Salt Lake, via Skype? And how do you make that work the best? And they're really trying hard to get high-end care out to the more rural areas, and that's going to be a big deal as we go throughout this next little while. What do doctors do to try and save costs? Well, doctors really aren't having a whole lot of success. They're getting gobbled up by people that are bigger than they are. Private practice in general has gone from 33% to 16% in the last 15 years, and in fact, I've seen some statistics that seem to indicate that private practice will go to about 5% in the next 5 years. It will be really rare to see a doctor on their own, not part of some system somewhere, a clinic or a hospital or something. The other big thing is that there's a shortage of providers, and particularly primary care providers, and that's going to cause some problems going forward in these accountable care models, because the high-end providers aren't the ones that are the cheaper ones. So you're going to see some nurse practitioners trying to take over the lowest end of care rather than having them be physicians. And if healthcare costs have a chance to be contained, there has to be some kind of mobilization of the doctors to be able to fight with the hospitals. The last one is pharmacy. And pharmacy is a huge problem right now. It has been relatively stable for maybe 15 years. And all of a sudden, it's exploded again. And the two big reasons are generic drugs and specialty drugs. So last year, the trend for pharmacy across the country was 13%. Specialty drugs, 1% of the population takes specialty drugs. Those are usually injectables, something that you have to go to the doctor's office to have them either inject or take care of, so they're not pills usually. Well, 1% of the population is on them, but that's 32% of the drug costs, and the expected trend of specialty drugs is over 20% going forward. So these are the high-end cancer drugs. These are the new hepatitis C drugs. These are the new exciting medications that do really well. In fact, we were talking about cystic fibrosis. There's a new drug that's about to be approved for cystic fibrosis that they think is almost a cure for cystic fibrosis. It really is one of the miracle things. And we said, how much is it going to cost? And they said $300,000 a dose. That's staggering. I think what a spectacular thing to be able to have this, that you can almost do all this good for this person, and it's $300,000. It's a 12-week course. That would be a dose. $300,000 for a 12-week course of this drug. But at the end, they think that's going to be good. The generic drugs is the other one that has a big problem right now. And generics, you've seen a lot of drugs go generic, but for the first time ever last year, we saw unprecedented cost increases with generic drugs. The example I have is tetracycline. It's an antibiotic used to treat certain kinds of infections. In November 2013, it was 3.4 cents per pill. In November 2014, it was $2.36 per pill. That's a 6,850% increase in cost in 1 year. Now that's an extreme example, but that gives you the kind of idea of why there's been a huge amount of consolidation within Big Pharma. So a lot of the big pharma companies have gobbled up these smaller ones that were producing a lot of these generics to compete, And they did it simply so that they could raise prices on some of these more popular generics. There's been a little bit of shortage of drug ingredients, but that's been minor to that effect, but that's been a big deal. So where's the money going to come from? Well, we have private insurers. Do they have any relevance anymore? You have all these complaints against private insurance companies about how they've been working, and the ACA tried to address all of those. So we had all these insurance reforms with the ACA, this huge number of mandates. The biggest one, as we talked about before, was preventive care. And it caused about a 2% increase in cost. And we've shown that when you cover things at 100%, it really doesn't give any incentive for the price to go down. And so what we've seen is contraceptive prices. Pharma was the first. They are more attuned to this than anyone else. But we've seen, on average, contraceptive prices rise 100% last year in 2014. There's no reason for it. There's no increased cost to production. There's no increased cost to anything about it. They simply say, well, no, the member doesn't have to pay it, and so we're going to increase prices. And the government has said, yep, you've got to cover it. And so they'll increase this as high as they possibly can until somebody steps in. Until they want to keep just under the radar, but this is going to keep going up. This won't be alone. Contraceptive, I'm not trying to pick on women's issues by any stretch of the imagination. This will be across the board with all preventive care. So if the cases are, if they're free to people, you're going to see increases, huge increases in the prices of preventive care in the next little while. So the cost of insurance is going to continue to rise because of that, both mandates and lack of cost controls, and you're going to have limited profit for insurance companies going forward. This talks a little bit about why insurance companies' profits are going to get squeezed, but that's here nor there. What will happen, though, is you're going to see a consolidation of insurance. And you've already seen it in Utah a little bit. So Altius has been bought by Aetna. And Aetna's a national company, and they've come in and swooped in and taken Altius. Regents Blue Cross has been around for years and years, and they still exist. They have laid off most of the staff that is here. They've left some marketing presence, but most of the staff has gone to other places where Regents is in Oregon or Washington. And so they're significantly smaller than they were before. Select Health has stayed as robust as they have always been. It will be interesting to see if they can make it work if Intermountain goes to this accountable care organization. Because if they go to accountable care, Select Health, it becomes more and more difficult for them to exist. I would think they will shrink as well going forward. So you're going to see a huge consolidation of insurance. It won't just be here, it's across the country everywhere. The benefit design rules have changed. We've talked a little bit about that. The big one that you want to look out for coming quickly is the Cadillac plan tax. So this is a 40% tax on health insurance premiums that are over a certain level. And so I think we've got the slides here. So if your premiums are over $10,200 a year for an individual or $27,500 a year for a family, then you will owe anything above that will be subject to the 40% excise tax. So most of you probably aren't here yet. I don't think anybody in Utah is that close, but by 2018 you might be getting close. If it's something you want to watch and maybe you want to project out, assume a certain rate of increase over the next few years and see kind of where you would land as far as premiums go going forward. It's certainly something that everybody's going to start looking at. One study found that 60% of all large group plans may hit the mark by 2018. And another study, because this is tied to regular inflation, everybody's going to hit it at some point. So they found that 98% of all plans will hit it by 2031. So it's coming. How you deal with that, it will be interesting to see. You can lower benefits a little bit. You can do things to try and keep that premium down, but it's coming. So those are all things that you'll have to worry about. This one's a little small. CalPERS is the biggest public employer in the country. public plan in the country. So they looked at two of their hundreds of plans on the Cadillac tax. They determined that in these two plans, they had 8,000 enrollees. The tax would be $3.9 million just for two of their hundreds of plans in 2018, or about $500 per enrollee. So the plan cost for their plan went from $2,000 to $2,500 overnight for the year. And you can imagine what that would do to their plan. And so they're trying to take steps to try and figure that out. It'll be interesting to see when this gets closer. We have another presidential election before then, and this probably won't be an issue then, but it's going to be an issue when we get closer to 2018. So what do we possibly do? Is there a way that we can save healthcare? Is it a market? One of the Republican ideas is that if you want to save healthcare, you try and make it a market as best you're able. So everybody knows what it means to make a market, and one of the big issues is that everybody has to know all the information related to healthcare, and that's really hard to do. But here's some things that we're trying to do at PHP to help people know better and to try and make it more like a market than maybe it was before. One of the things that we've done is we've tried to encourage cost-conscious plans. And what we mean by that is we've tried to reduce the use of co-payments. Co-payments are a fixed amount that you go to the doctor, you pay $30 or whatever it is, and you go and you have your service done. And we've tried to encourage co-insurance because co-insurance is a percentage of whatever the price is for the doctor. And that makes the consumer more price sensitive between doctors or between hospitals. So the other thing we've tried to do is encourage people to consider a high-value HSA plan. And what we mean by that is if someone says the deductibles are say $1,100 and $2,300 and preventatives at 100%, we've tried to say you need to fund 80% or more of the deductible with an HSA. That would be the high-value HSA plan, is to try and fund as much, or up to 80% of that deductible, so that the people are still price sensitive, but it gives people more ability to say, this is coming out of my pocket rather than out of the employer's pocket or someone else. So here's some estimated savings we have from, these are PHP groups from a few years ago, if they move to a high-value HSA plan. And you can see that there's significant savings that people might have there. The other thing that we've tried to do is give people tools to be able to determine what costs of healthcare are. And so this has sort of been the black box of healthcare for years and years. I remember I had to have surgery, this is probably 10 years ago now, and I went into the doctor and I said, can you tell me how much this is going to cost? And the doctor said, I have no idea. And I said, well, it's going over to the hospital, and they said, well, can't you give me the code that I can ask the insurance company? And they said, well, we don't really know what the code's going to be until after we perform the service. And I said, well, that really doesn't work. I said, what can I possibly do to figure out how much this is going to cost before I go in to have this procedure done? And they said, I don't know what to tell you. You either want the service or you're not. You just have to deal with whatever the costs are, if the costs are. And that was extremely frustrating. But this idea is trying to get at what the costs are possibly going to be going forward. So we have this ability to look up what the costs are going to be. You can look it up by provider. You can look it up by location. You can put in say, what are the costs or the treatment within a certain location within 10 miles or whatever of your address. And you can browse by different procedures, and you can kind of see what the options are as far as what it looks like. So here's what it looks like. So you get a cost estimate, and it will give you a low, a likely, and a high. And then it gives you kind of how your benefits would work with each of those costs. And you can kind of go through and see how that would work. And then if you wanted to compare different providers, it will pull drop down about how each different provider costs would work, what your copay would be, what your coinsurance would be versus each of those providers. And it will tell you exactly what the cost would be for each one of those as they go forward. So this was for, I don't even remember what it was, cataract surgery, I think. And you can see the different providers up there and what their costs would be, and there's small differences. And then it tells you how far away they are from you and how you want to make that work. That covers 90% of the codes that are out there. There's still some codes that don't fit into that tool very well. And so we've created a separate code that talks about the quality and code lookup. You can look up a particular provider, particular physician, and say how much is this particular code, and you put in the code and it will tell you exactly what the cost would be if it's not on the other list. So that's the other piece that's there. So the other piece is how do you measure quality of providers? And you talk about, we have the cost info, but is this provider better if, if their costs are higher, doesn't that mean that they're more popular? Or maybe they're a better provider because their costs are higher. Maybe. So we have a way to rate providers on the website, and has some good and bad to it. I mean, rating providers is not a perfect way by the members, but there's other ways that we've done that. We've also tied it into some of the state of Utah hospital comparison reports by the Department of Health, and to be able to see what kind of the quality is of different providers going forward. The provider rating is all on the EOB, so you can go straight from it. If you get an electronic EOB, you can do write it on there, and you can kind of see how that works. As the quality code lookup, you can look on here and you can see this person has a 5-star rating as opposed to some of the others as you're looking for providers on that list. And you can drill down the drugs. Similarly, on the drug side, we use Express Scripts as a PBM. They have a similar idea about how much drugs will cost. Are there other alternatives to drugs? If you look up the drugs, what's your best option as far as your drug choices if you have a particular condition? The other one we have is we have multiple networks. So we have an Intermountain network and we have a non-Intermountain network. The Intermountain network is called Advantage Care, and the non-Intermountain is Summit Care. And there are differences between those as far as costs go. You can see that they work out to be almost the same, but for a particular service, there may be surgery or imaging centers that can save you a significant amount. And so we try and help people understand where they can go to get the cheapest, the best care for the lowest possible price. The last thing that we've done to try and help people understand their medical condition and what they need is we've partnered with a group called Wiser Together, and they've tried to help people make better healthcare decisions. And their whole idea is that if you can try and put in some basic information about your health concerns, that we can try and help give you ideas about what will work for you best, not necessarily what will work for the provider best. So, this talks a little bit about what they were going to do as far as how much this is going to cost, how much is it going to work for you. So if you do just a Google search on back pain, or if you go to WebMD on back pain, it will tell you, maybe 2 different treatment options ranging from spinal surgery to heating pads to yoga to a chiropractor. What's the best one for you? Well, it kind of depends on where you are. And so they've created this tool. Maybe this will, I don't know if this is going to work or not. We'll see. But it talks a little bit about, it creates a bullseye that you can show what your preferences are and how this is going to work. So let me just see if I can, apparently that's not going to work. Let's see if I can go back here. And what it does is it gives you options here, and we call it the treatment advisor. So if you know you have high blood pressure, you go and you say, how long have you had high blood pressure? What have you tried? What have you done? How has this worked for you? It will say, okay, these are the things that are most effective for people with your condition with high blood pressure, and it gives you a range of options that will work for you rather than trying to rely on WebMD or some other Wikipedia or some other way to try and figure out what to do with your health care. So we also have a couple of things on the website about cost-saving tips. we're trying to do everything we possibly can to try and make it easier for people to save money on their health care. And we've given a bunch of these different coverage traps and different cost-saving tips. For example, is it better to go to the urgent care or to the ER? Depends on what you have, but obviously if you can go to the urgent care, you're talking about $119. If you go to the ER, you might be talking about $1,400. So you can get an idea about what we're trying to do to try and move people to the right level of care. If you can have a procedure done in an office rather than a facility, it's also cheaper. So we try and give people an option about going to an office. Colonoscopy is the perfect example. If you go to a colonoscopy and someone can do it in their office, they typically can do it for about $500. If you end up at a facility somewhere, it's usually about $1,500. This is also a little bit about what part of our wellness program, and it gives you an idea about what your health snapshot is, about where you stand right now. So if you're trying to look for takeaways about what you can do to try and help costs, go to a cost-conscious plan, particularly a high-value HSA qualified plan. And the other thing is, if you can get cost and treatment information to employees, they will be much more empowered, have a much better chance of making your healthcare costs go down than if they have no information. It's a black box to them, they don't know what to do. Okay, the other one is reducing complexity. How do we do that? Nobody really has an idea of what the ACA is going to happen with, but one of the things that we have with complexity is we get a lot of people that get caught with different coverage options. We talked a little bit about that before. But we have a couple of examples on here. So someone failed to get a pre-authorization for a genetic test. Genetic testing is going to be a hot issue going forward. It was $9,500 for a genetic test that did absolutely nothing for the person. Yet the doctor said, I'm going to order it. They got their lab done, $9,500 later. PHP said, that's really not necessary. And the person says, what do I do with this $9,500 bill? I didn't even have any idea. And that was one example. Another example is they failed to send the person in network. So they went to the doctor. They said, here, you can go see this magnificent person over here at the Mayo Clinic. And it's $21,000. And they said, well, I thought my insurance would just cover me to go to the Mayo Clinic. And we said, sorry, you need to stay in state if you can. And that they left them with a $21,000 bill. The last one was failure to comply with the policy. There are several times when people will upcode anesthesia is the big one right now. So you'll go see a doctor for a procedure. The procedure will require some level of service. But the doctor says, no, we need to really ramp that up, and anesthesia is the perfect way to do that, and so they end up billing $1,000 extra, or in this case $650 extra for extra anesthesia services that they didn't need. And they didn't comply, and so we said, we're not paying for that extra, and so the doctors tried to bill them extra. How do you deal with those? What do you do? You just say, well, insurance, you just ought to pay. And that's one way to do it. And that's sometimes what happens, honestly. How do you deal with that issue? Do people take some kind of responsibility? So do they have to ask every time, is this the right thing to do? How do we make that work? I don't know if anybody has any horror stories of their own they wanted to share, but that's a pretty common thing, that they thought something would be covered, and then it turns out not to be. That's a hard one.
We've got that problem right here in St. George, with Dixie Regional and Coral Deserts. They share the same doctors, but one facility is in network and one isn't. And our employees will have surgery scheduled with the doctor, and then they'll choose the facility, and we'll get the bill later that the facility wasn't covered.
Right. It happens a lot with Intermountain and the University of Utah, especially at Primary Children's. Sometimes they'll cross networks there, and I think that's those are the two most common. There's the St. George issue and the Primary Children's issue. So that's absolutely true. The other thing we see is that we have some doctors that have no regard for cost, or hospitals or whatever. So they'll have a prescription drug and they'll be able to say the brand drug is $1,800, the generic is $15. And they said, well, I don't care, I'll just go out and put you on the brand drug. It doesn't make any difference to me. Or they have maybe some financial incentive or some research incentive to put them on the brand drug, and we see that happening a lot. And then we have sometimes, although this is rare, we have providers that sometimes will just refuse to contract at all with anybody. And so we had a hand surgeon who does plastic surgery. Most of their stuff is cosmetic. They just said, I'm not contracting with any insurance company. People want to come see me, they pay me directly. The problem is they also work in the ER. And so then they come into the ER and they have this service done, and then they say, here's the bill, and there's no contract at all, and there's nothing anybody can do, and they just say, it is what it is, pay it or don't. We don't really care. And they're going to go on their way. So all of those are troubling. So one of the things that we've found is that education is very important for the members. The 3 questions that we encourage people to ask every time is, does this require pre-auth? Number 2, is this provider in network? And number 3, is there a less expensive alternative? And if you can get to those 3 questions, that will solve 95% of the problems. So if does it require pre-auth? Are they in network? And is there a less expensive alternative? So the 3 takeaways from complexity. So keep your eye on the ACA. There's continued employer shifts about what benefits are going to be covered and how that's going to work. That's not something anybody can control, but some of your brokers and others will work with you on that. But it does push the 3 questions is the one that I really want to emphasize today. Does it require pre-auth? Am I in network? What's the alternative? And then if you want to use the ratings tool, I think those are good things to use. One of the last ones we're going to talk about is the fragmentation of care. One of the things that we've found is that there are some people that their health care is simply out of control. They have no ability to control it themselves. Maybe there's mental health issues involved. But you simply have someone that goes to the ER every 2 weeks. And it's like clockwork. Sometimes they're drug seekers. They're looking for pain pills. Sometimes they're just looking for someone to take care of them for a little while. And the hospitals have to take them. And you'll see this cycle go through around and around and around again. The member's not really improving. They don't really know what to do, or they're facing serious illness. So one of the things that we've tried to do is personalized care coordination. We've tried to connect these individuals on an individual basis with a specific provider, and we have them report on a much more regular basis to both the provider and to PHP. We've given them incentives to do that, to try and report on this regular basis to see if that has been helpful, and we've found some really good success stories in being able to do that. Some of these people, they simply want someone to talk to. That's as dumb as I can think of as far as a reason, and they have $200,000 in healthcare costs for someone to talk to on a regular basis. And I'm just amazed that these people have jobs and seem to be otherwise productive, and yet on the weekend they go to the ER to be able to talk to somebody. So we found this is a much better way to go. They may have some residual issues, they may have back pain issues, but we found that there's a much better way to handle these people if we can use the personalized touch to be able to get them to the right place. So the biggest thing we've had is this individual benefit advisor and help them get to a single point of contact. The other thing that we found in fragmentation of care is that the employer penalties are going to be a big deal in trying to get all benefits up to a certain level. And so you've seen these new reporting requirements, but one of the biggest issues in trying to get this all to work is the HIT tax. And maybe you've heard about the health insurance tax that applies to everyone that's fully insured. It's mostly seamless to all of you because the insurance carriers pay the tax. But there's an exception if you're self-funded. So if you are self-funded, in other words, that you pay your own healthcare costs, you can avoid the HIT tax, which is about 2 to 3%, depending on where you are each year for your health insurance carrier. I can guarantee you that health insurance carriers are passing it along to you, but if you can self-fund, you can avoid that tax.
When you say self-fund, does that mean like if the county is self-funded?
Yes. Yep. Exactly right. The other thing about self-funding that I think that is important is that your efforts still matter if you're self-funded. If you're fully insured, you get dumped into a pool, and the pool absorbs all the costs, and if your employees are healthier than the pool, you really don't get any of the benefit. The other employers that participate get the benefit of that. So all your wellness programs, all your ways to try and reduce healthcare costs get absorbed by someone else, not by your own employees. So when you self-fund, your efforts still matter. It matters what your culture is. It matters if you reduce costs. It matters if you engage employees. It just doesn't matter as much if you're fully insured. So one of the things that I liked your presentation about creating a self-funded culture, it helps preserve your healthcare benefits. If the costs keep increasing, you simply are going to have to reduce the benefits in order to survive. Price and quality matter, and your wellness programs matter. The other thing that is interesting is I've heard a lot of talk about wellness or employee clinics. This has sort of become a new buzzword around. You've seen some larger public employers in the state that have provided their own internal health clinics. They'll hire a doctor. The doctor will be able to see the employees during the day. They'll have patients regular time period. And it's helped increase morale, and it's helped increase people at their desk at work rather than some other ways, trying to take work off to go see the doctor or something else that happens. It also helps keep the profits with the employer, because the employer is the one that receives the money. If there's any profit that comes from having the doctor there, the employer gets it rather than somebody else. Does anybody have one, by the way? Any employer clinics out there? Just wondered how it was working. No Salt Lake County here, representatives? All right, just wondered. I know they've had one for a while. The other thing is that patient changes. You're going to have to see people get more involved with their health care, or we're doomed to a one-payer system. I mean, that's going to be the choice of America going forward. Do they take responsibility for their care? Do they care about price and quality? Or are they going to move to say, I don't really want to worry about it, just shove us all into some system, to the government system over there, and let them take care of us, how that's going to work. So you have to shop for care. And it takes education to know about where the prices are going to be. How do we make that work? But there has to be shopping for care, or none of this is going to work. None of it's going to matter. Patients are going to get marketed to. Drugs are going to be the tip of the iceberg. The more you make it a market, the more people are going to see, ads for hospitals or ads for specific doctors going forward. And we have to take increasing responsibility. So the last part is the government is sort of the big wild card. What's going to happen politically? Will costs perceived to have come down? The big one-payer system is still out there, and there's still people that want to push for that. Insurance profits are going to be capped, and so you're not going to see that being a cost driver so much anymore, but the cost control options are going to be limited in the fully insured market. You're really not going to be able to do that, but it's easy to see how that could lead to one-payer system. The best part about it is that large employers, and by large I mean 50 or more employers, really have the chance to save the system. If they can get together and really get costs under control in their individual employment and their individual plans, you really have a chance to turn the tide. I believe that. I'm maybe in the minority about believing that, but I believe that the responsibility is really with a lot of you about how to make that work, about the education, and about how we can turn the healthcare system around to make it more robust, better for everyone. So, all right, positive, well, not really positive. But I know one thing for sure, is if costs can't be contained in some way, the system's currently unsustainable. We probably won't last 15 years with the way the current system is going to go. So it depends on everyone here. I'm happy to answer questions. If anybody has questions, I'm happy to talk to anybody. If you want to, you've got my email address. If you want to email me anytime, I'm happy to do that.
On the insurance stuff, I know one time I went to the pharmacy and it's not covered under your insurance, so you have to pay it. So like, let's say they charge me $20 for the product. Then I call the insurance and say, well, how come you didn't cover it? You know, I have you guys cover for anything like that. Well, we're missing information from the pharmacist. So they call the pharmacist and say, okay, we get this information, now it's covered. So I go in and they refund my $20, but let's say they bill the insurance now $40. Is that
Unfortunately, yes. See, one of the frustrations, and pharmacy is the best example of that, is that they bill sometimes a lot more than what it really costs. And so they have this idea that there's one price for insurance and there's one price for individuals that go in there. And that's really a difficult problem. As an insurance group, it's difficult to get your hands around that, how to make that work. There's a couple of strategies that we're trying to make that work better, but it really does become difficult.
Can I ask a question on the reporting for the ACA?
Sure.
So I asked the question earlier, but nobody's answered. So I'm wondering if you have to use like May 1st, May 31st, or if you use pay periods during that?
We use whatever you need. So from our perspective, we look at it and say, from when you report, you're reporting on a calendar year. And so there's some transitional relief that you can split up the year depending on how that works. But we will use the calendar year to report to the feds. But as far as your look back period or how that's all going to work, that's totally up to you. And we'll have to work with you to figure out how to make that work. Does that help you?
I was just wondering about the dates for sure, because I know it's a lot easier for me to pull a pay period than it is to
Right.
pull one through.
No, we can do it by pay period too. That's not an issue for us. Do you have a question back there?
I did, I mean, I think you kind of answered it, but, on the report that you send in, the employer has to provide you the employee counts every month, right?
Right, but who's hired, who's terminated, that kind of stuff.
And how many hours they work?
So they have to tell us whether they're full-time or not. So if they work more than 30 hours, that's what we need to know. Are they full-time or part-time?
All right, so you just need to know whether they're full-time or part-time.
That's right.
You don't
So
know
full-time for the ACA purposes is 30 hours a week or more, and part-time is 29 and a half or less.
So we as employers still need to determine whether they're part-time or not by
Right.
doing our calculations on the
Right,
spot.
that's right. PHP doesn't have that piece of the information, so we have to get that from them.